Thanks, Inka, and good afternoon, everybody. Good to see some familiar faces there. Reinhold's giving a little wave. Thomas, want to give us a little wave? Showing everyone still active and awake. I hope you're up for one more presentation today. And of course, delighted to join the ENMESH conference, the 13th and a half. I certainly have very fond memories of attending most of those early ones in Leipzig and Verona and Santander, as well as London and other places. So great to be connecting again. And I think I particularly have Mike Slade to thank for making the link for this particular session. He was in contact with my colleagues, Michel Funk at headquarters office about the topic I'll be speaking about today. But thank you very much also to the ENMESH board for inviting me to talk, and it's somewhat fit given that ENMESH was inaugurated under the auspices of WHO Regional Office for Europe all those years ago. We don't want to really say the number. But so today, let me share my screen. Here we go. Yeah, so the topic today was going to be on promoting person-centered and rights-based approaches to community mental health services. And it will build somewhat on what Graham was talking about. But I particularly wanted to talk about some new guidance that has just been released by WHO and talks or refers very much to the issues of concern to all of us in this group. So let me start first with some contextual remarks and just start with some of the main challenges that have been facing European countries and continue to do so. We've just been in the process of developing a new so-called framework for action on mental health since the WHO European Action Plan on mental health for 2013 to 2020 expired recently, and so been working on a new one, and of course that's a time to reflect and look back at what the previous plan has achieved, but also what are some of the main challenges that it sought to address and which ones have been satisfactorily met or addressed or not. So I think some of the ones that are actually listed in this now draft action plan, which will be hopefully approved by the member states in September, include this half dozen challenges. The first is around stigma and discrimination, the low levels of mental health literacy in the general population, which partly feeds into that discrimination against people with mental health conditions and psychosocial disabilities. Of course, the insufficient investment in and access to good quality services for people over the whole life course. The number of countries where we see, for example, a horrible shortage of services available for young people is particularly startling, but actually it's pretty much true for older adults as well. And then the well-known problems of fragmented and uncoordinated delivery of services, particularly this issue between the health and the social care services or sectors. Sometimes ministries are in accompanying or neighboring buildings, but never actually talk to each other or plan anything together. And that's partly an issue of governance, of course, inadequate governance, and also poor information systems and surveillance so that there isn't good intelligence to inform planning and policy. And finally, and this is what I wanted to sort of focus on, is the continuing reliance on psychiatric hospitals and social care institutions in many of the countries. And the more east you go, the worse it gets in many ways. as the primary locus of mental health care. And that is particularly salient to the topic around today's presentation about the need to move towards more person-centered and rights-based community-based services. So I want to say a bit more about that. 2 or 3 years ago now, we did a big project across more than 20 of the European countries or member states that looked at the human rights and standards of care in institutions. And this used a tool which is being developed by WHO called Quality Rights. And it essentially takes the CRPD and a number of its core articles and translates it into an assessment tool. And then on the back of that, several other training and guidance packages and materials which are aimed at improving service standards and better protecting the human rights of people with psychosocial, intellectual, or cognitive disabilities. So some of the key articles that are specifically addressed include standard of living, levels of physical and mental health, opportunity for legal capacity and personal liberty, freedom from torture and abuse, and finally, opportunities for independent living in the community. So these are 5 overarching themes, and within that, there are several criteria which are used to rate the extent to which these standards are or are not being met. And the scoring system is on the left here, which is basically a qualitative assessment of whether those standards have been achieved in full or partially, or not initiated, or partly started, initiated but not achieved, or indeed not applicable in a few cases. So I'm just going to show here on the right-hand side some overall findings across these 5 overall 5 domains. And what you see is, with a simple kind of coloring system, is that if you just concentrate on the green, you can see that only a small minority of these 75 facilities that we were able to assess across 25 countries were fully meeting the standards and standards set out in the CRPD. And if you look at the dark red blocks, those are the ones where there is particular concern, where issues, for example, around opportunities for independent living and also concerns around legal capacity and personal liberty are very clearly coming out as not being addressed or even initiated. So overall, we found that the total, scores across these 25 countries and 75 facilities was that only around a quarter of the ratings were achieved in full. So it's basically saying that there is a huge gap in quality of care and rights-based approaches being pursued in these facilities. The situation, of course, has become a lot worse and exacerbated by the COVID-19 pandemic. And back in the summer at this time last year, we initiated, again, an assessment in some of these institutions to see what was going on there, because no one else was looking at this, it seemed. And a sort of snapshot survey across 170 of these institutions that assess the extent to which assessed a number of themes around the availability of information and the communication of that information to residents, infection prevention and control standards or levels, the actual delivery of care and services and disruptions to that, as well as the impact of the pandemic and its associated restrictions on both the staff and the residents. And so just some snapshot, some some highlights of that assessment. For example, 80% of these facilities reported additional challenges for staff, such as the increase in workload, the stress, the frustration, the burnout, the worry of not having PPE, and so on. In over 60%, they reported additional challenges for the actual residents, such as, again, increases in agitation, distress, challenging behaviors, suicide and suicidal behaviors. And more than 40% reported actually an increase in use of restrictive measures, such as seclusion and physical restraint. So again, a pretty damning indictment of what is actually happening in these facilities, and how the COVID pandemic has just accentuated the challenges and the problems in those settings. So following that, so just on this, some of the key considerations for how to better respond over and above actually closing some of these institutions would be clear guidelines and tested systems that are actually in place and ready to be implemented at short notice. Clarity of communication, having a proper IPC, infection prevention and control plan, procedures and protocols for safe environments and issues arising from necessary measures, particularly around isolation and communication. And also exhortation really to focus on ensuring a person-centered and human rights-based care approach. That's again part of the context for what I will come to shortly. And finally, just to say that Graham already touched on this a bit earlier, that WHO did do a rapid assessment. So rather than many of the research papers that he alluded to, and there's this vast literature out there already, this was more being a kind of questionnaire sent to the policymakers in countries and saying, how much have you been taking health into account in your COVID response plans? Have you seen disruptions to services? And of course, the answer was yes, huge disruptions. For example, in the European region, the 26 countries that responded here, in 40% of those countries, the services had been disrupted in at least 75% of service in service settings. So there is actually, building again on what Graham was saying, WHO Europe did set up at the beginning of this year a technical advisory group on the mental health impacts of COVID. It's just finished its work and will be producing its report very shortly. We're just finishing the final touches to it today. And a bit like Graham was saying, very much reflecting what he was talking about. And this was the first meetings sort of output where these 28 members of the TAG group, kind of free associated about what they saw as the key issues and impacts and what needed to be addressed by the TAG. And it fell into this, as Graham was talking about, the general population community impacts, the mental health services themselves and the workforce, but also these vulnerable groups, including healthcare workers, people with long COVID, and those with pre-existing disabilities. So I really don't think this is the source of the main point of my talk. So I'm not going to go into all of this. It's a very busy slide, but I try to get all of the recommendations on one. It's basically saying, look, here are these different groups and here are the impacts and some essential needs or recommendations for countries to consider. And as I've highlighted here, a lot of it is about basically enhancing access to appropriate mental health and psychosocial support for those who have been affected, which is, as you can see from this list here, a great many people. So this is all by way of context, and I want to get on now to the guidance itself on promoting person-centered and rights-based services. So the idea here is to partly building on some of these earlier guidance and documents, including quality rights, but other guidance policy related guidance materials. But this the specific aims is to really demonstrate that services that are person-centered and rights-based can be developed, have been developed, and could be developed much more widely across countries, and to try and inspire, I suppose, service planners to develop these services. So this is the overall aim. And it provides this is the basic structure of the new guidance that was just launched on the 10th of June, so just a couple of weeks ago. Provides some context in terms of the international human rights standards and recovery approach, which is rooted in CRPD, providing some summaries of good practices that have been seen and implemented across the world, as well as being properly evaluated, and then looking to provide some clear steps on how you can move towards services that link with other sectors and integrate these good practices into across those sectors. It looks like a lot. There are 7 separate elements to this. Regard them, I suppose, as like chapters. Is covering everything from hospital-based mental health services and community mental health centers through to specific pieces on supported living, also on peer support, mental health services, and as well as crisis services. So yeah, a description of what they are, what they mean, what are some of the well-known or commonly established challenges and solutions to overcoming them, as well as some practical steps for setting up those different types of practice. And to inspire people, there's a whole range of different examples from, as I said, across the world to support the recommendations and guidance that are in each of these chapters or manuals. So this is the essence of it, and these services that have been highlighted in the guidance were essentially there was a huge number which were sort of vetted or identified, but then when it came down to it, there was need to identify those that met certain sort of core criteria, and these are listed here. So when we talk about person-centered, rights-based community mental health services, we're talking about those that really respect people's legal capacity, are implementing strategies to end coercion or restraints, a focus on inclusion of people in the decision-making and running of services, the links to relevant other services and supports in the community, such as social protection or employment opportunities. And a final one was around the provision of person-centered care that address relationships, the work, family, and education, and not just a kind of biomedical approach that looks at the diagnosis and the treatment plan and symptom reduction. Overall recommendations that are set out in this guidance are some fairly familiar friends. So the need for political commitment and increased funding to scale up rights-based services, but very importantly also the legal and policy frameworks that enable those to happen. And unfortunately, that's often a very long and arduous process to change the legal frameworks in countries, whether it's bespoke mental health legislation or integration of mental health legislation within the laws of the other general laws. And that's one of the reasons we see so many countries with extremely outdated mental health legislation. Then moving to the training, a clear need where when you do these assessments, there is a a clear evidence of a lack of knowledge and awareness about mental health and human rights, even amongst mental health workers in mental health services. So there is a clear need to further roll out the opportunities and access to remote as well as face-to-face training on rights using a disability a model and a person-centered approach. Of course, we need more data. I was showing you a bit more. Graham and others have also been pointing to some of the key data that can help to underpin this, but there is an ongoing need to improve that, particularly, I would say, on service user outcomes around their experiences with services and the actual outcomes of their contact with services. And then there's a nice link to ENMESH, so improve funding for research on services that use a rights-based approach, and finally engagement of people and organizations of people with psychosocial disabilities. So that was what I wanted to cover in the presentation, and I'll just finish maybe with some sort of overall concluding remarks or reflections. So, you know, of course, most of the last 18 months has been spent fighting, addressing COVID-19, and particularly from our side, you know, in this group, the mental health aspects of that. And so what can we draw from that? I think one of the obvious things to say is that really public mental health systems and services throughout Europe were really chronically underprepared for addressing the mental health impact of a pandemic like we have seen. They were unaddressed in many respects, but certainly when you think about mental health services and needs at a population level. Of course, there were huge disruptions, as Graham mentioned, as a result of the need for ramping up of COVID wards and the implementation of restrictive measures to counteract the pandemic. You know, the mental health systems, you know, they were really challenged, you know, to adapt very quickly and be able to innovate, particularly obviously the telemental health became a necessity. And, you know, you could say that's a win, you know, because that was moving very slowly. So what has happened in 1 year might have otherwise taken 5 or 10 years. So the one concern on that is, of course, that, well, not everyone has access to digital means of care and support, but also concerns over you know, the way things were rushed through, that a lack of appropriate oversight, regulation, ensuring confidentiality of service users and so on. So right now, I think, you know, public mental health systems and services are somehow expected to cater to a whole new set of needs and demands and new modalities of support, yet remain chronically under-resourced to deliver high-quality integrated care to those in need. So, of course, all the things that were in the previous slide, so more political commitment, more resources are evidently needed. But above that, 3 things here. One, I think, you know, this pandemic has just shown so clearly even more so the need to move the locus of care away from institutions, as I've tried to show, and therefore, consequently, pursue a much more person-centered, rights-based, community-based approach to service development. And by doing that, in so doing, working more closely with other sectors, services, and community constituencies in doing that. So I'll leave it there. Thank you very much for your attention, and I pass it back to Stinker.